So the question is, how is stress MRI done? How do we do it? Okay, so vasodilator stress, okay. Is there any other ways you could do it?
WM.
Okay, you could do DeBakey. And then, so when you're doing vasodilator stress, what are you looking at?
Shift of blood supply.
Okay, so perfusion. Perfusion. Okay. When you do DeBakey, what are you looking at?
Wall motion.
Wall motion. Okay. Is there any other ways you could do stress MRI? Well, so how do you do stress testing in general?
Treadmill.
Okay, so exercise, right? So some kind of exercise. Can you do MRI? Exercise?
No.
Logistically,
Okay.
We get into the madness, no?
Yeah, so let me go through. So first of all, to do any kind of MR stress testing, what do you need? You need, obviously you've got to have a good EKG signal, and the screen's really bright here. You need MRI safe IV pump. You need a power injector, and then you obviously need a monitoring system to be able to monitor the patient. So we have actually a MR compatible monitoring system which allows us to monitor telemetry and pulse ox and blood pressure while the patient's inside the scanner. All right. So can you
bring it down a little bit?
Yeah, bring the brightness down. It's only for when I play the images that we need the brightness up. Otherwise, it's too bright. So actually, there are now a couple of MRI compatible exercise protocols. All right. One on the right-hand side, this is a group at Ohio State's been working on, which is an MRI compatible treadmill that they put in the scanner room next to the MRI scanner. And they have to quickly, once you get to peak exercise, quickly get the patient on the scanner and do wall motion imaging. So it can be done, but again, you'll see it's not necessarily the most simple to do. And then on the left-hand side is actually a bike, ergometer, that goes into the MRI scanner. So in this case, the advantage obviously here is you don't have that limited window when you take a person from the treadmill and move them onto the MRI. You can have this person continue to exercise and then try to do wall motion based imaging while they're exercising. Obviously the reality is it makes it challenging because imagine trying to exercise and then trying to do that now inside of a little tunnel, right? It's not always the easiest thing to do. So that's why I say, these are, I think, still kind of proof of concept and still in the developmental phases. But maybe one day we'll have a way to do that. The thing obviously MR can be useful for when it comes to coronary evaluation certainly is coronary MRA to look for anomalous coronaries. I think that's definitely an application where it's used today. And there's numerous studies going back to the 90s and 2000s showing pretty good diagnostic accuracy at identifying a coronary anomaly. And the advantage in young patients where you're concerned about radiation exposure is MR doesn't have any radiation exposure, unlike CT. So the two main techniques, though, that are used clinically is dobutamine MR, and then we'll talk about adenosine vasodilator MR. So dobutamine MR is done very similar to dobutamine echo in the sense that you will start with resting images and then gradually up-titrate the dobutamine dose to try to get an increase in heart rate, an increase in contractility, and then you look to see if there's any areas of wall motion abnormality. And I'll show you, okay, so maybe if you can up the brightness a little bit, sorry. So the top images is resting images, and what do you think about the resting images? So you've got basically 3 short axis cines, a 2-chamber view, and a 4-chamber view. What do you think? Yeah, so normal wall motion at baseline. And then the second row is 10 mics, and that's good enough. Yeah, that's fine. Second row is 10 mics, and again, the 3 short axis, a 2-chamber and a 4-chamber view. And then actually, if I scroll a little bit to the right, there's also another long axis view as well. A 3-chamber. What do you guys think about it? 10 mics? Anything? And again, you're looking for the same thing. You want to see augmentation and contractility of all the walls. You want to see that the cavity size gets smaller during systole. Anything? Okay. And then the third row now is at 20 mics. And what do you think at 20 mics? Okay, the base where? Talk about this area right here. Yeah, and be careful. Remember, because you'll see this in stress echo as well, right? That very basal part oftentimes doesn't fully augment. So, because again, you're up near the membranous septum, right? So that I don't know. I call too much on the interseptum here. Looks okay, right? So, aside from that area, anything else stand out at you? And then what about at peak? This is 40 mics now. What do you think?
The cavity at the end system is not decreasing in size at the same location.
Yes, in which location?
The septum, mid-septum.
Okay, the septum.
Yeah.
Yeah, and again, this one I'd be careful with because, again, it's up near the outflow tract. I mean, you certainly see the septal wall here all the way down to about this level. Looks like it's contracting, right? So that one, I'll just tell you, that's oftentimes you'll see that because, again, you're in that area, at the crux of the heart. But is there any other area? If you look at the cavity. Yeah, look at the lateral wall, right? See that? You can see it even this little area here in the mid-lateral wall doesn't seem like it comes in as well as all the other areas do, right? So there's a small little wall motion abnormality in the lateral wall. And in this case, if you look at and also we have obviously the ability to do delayed enhancement MRI. And what do you see on your delayed enhancement MRI at the end? And again, remember you're looking for areas of bright that represent myocardial infarction. So there's actually a subendocardial infarct here in that lateral wall, right? So this is an example, I think, of a case where there's subendocardial infarct with an inducible wall motion abnormality in that distribution. All right.
Can you point to the brightness?
Pardon me?
Can you point to the brightness?
Yeah. Let me. Okay. So you see how? Okay. Look at the myocardium here is black, right?
Mm-hmm.
This is the cavity, right?
Right.
What is this area right here?
Oh, okay.
Okay. Because I'll show you that on the short axis. Let me zoom this up a little bit. Okay. You see that area right there?
Yeah.
Yep. Okay, so there is and then if you look at the long axis view, and let me zoom it up here. Same thing. You see a small little subendocardial infarct here. Okay. So this is with dobutamine, and how good is that? So there is data that actually this is a study that's about 15 years old now, which was a direct comparison. 201 patients referred for cath. They all underwent dobutamine echo and dobutamine MRI, and you can see sensitivity and specificity of dobutamine echo was higher than for dobutamine MR was higher than for dobutamine echo, as well as a positive and negative predictive value. So there's other studies as well, but I think this is probably one of the first kind of large-scale study in everyone getting cath, comparing directly in the same patients. So I think dobutamine MR is an option. The challenge, obviously, with it is that it's time-consuming. It takes probably an hour and a half in the scanner to do because you have to up-titrate the different stages of dobutamine. And ideally, what you want is you want a stress test that you can do very quickly, that you can analyze very quickly as well. And then other limitations of dobutamine, in addition to the time, is oftentimes it can be hard for patients to tolerate getting a dobutamine infusion while they're inside the bore of an MRI scanner. And then lastly, the challenge is that in the MRI scanner, you don't have the ability to monitor ST segments. Okay, so that's one of the limitations. You can monitor the rhythm, but you can't monitor ST segments. So people are working on that, but currently the magnetic field disturbs your ability to be able to monitor ST segments inside the scanner. So it's distorted by the magnetic field. And so that's why probably a more preferred technique is to use vasodilators to do CMR. And then this is done with perfusion imaging. Now obviously if you look at the ischemic cascade, the other advantage I think of perfusion is that perfusion abnormalities tend to be the earliest manifestation of disease, with regional diastolic dysfunction and regional systolic dysfunction developing as there's greater and greater levels of reduced blood supply. And then obviously with severe reduction of blood supply, you actually can get resting EKG changes as well as anginal symptoms. Now, this probably in the nuclear talks, they probably touched on this already, which is, what's a basic principle behind when you're doing vasodilator stress testing? Well, the idea is you're not actually inducing ischemia. What you're doing is you're not causing hyperemia to occur. And so, this actually was some pretty nice studies that were done by Lance Gould over at UT many years ago in animal models, looking at the fact that the coronaries are able to auto-regulate pretty well, so that even if you have a 70% or 90% stenosis, resting blood flow may not be that impaired. It's only really when you get to greater than 90% stenosis do you begin to see any impairment in resting blood flow. But up to this level, the coronaries are able to auto-regulate pretty nicely. But where you will see differences is when you administer vasodilating agents. In a normal case where there's no stenosis, you get a significant augmentation in blood flow to the order of 4 to 6-fold increase. When you have a 70% stenosis, then you get a reduction in this rate of augmentation. And if you have a 90% stenosis, you may have very little at all in the way of augmentation. So as a result, you begin to see impairments in coronary flow reserve when you get to about a 70% stenosis. All right, and so that's the idea behind vasodilator testing, is that areas that are supplied by a stenotic coronary artery will not augment as much. And so if you have more than 70% stenosis, you essentially are going to get a 50% or more reduction in vasodilated flow. So with CMR, how do we measure flow? How do we measure perfusion? So the basic principle behind this here is that we're using a gadolinium agent, gadolinium contrast, which is a T1 shortening agent. And so what that means is just simply if I do imaging using a T1 weighted technique, then any areas where there's more gadolinium contrast, i.e. more blood flow, will have an increase in signal intensity. And what we're doing, you'll notice though, is we're doing this we began running the sequence even before we began to administer the gadolinium. So remember, there's two things here. One is you're causing vasodilatation, and that can be done with either with adenosine or regadenosine or even dipyridamole. And then secondly is you're doing perfusion imaging to actually look at what is the rate of blood flow into the myocardium. And then with this technique, what you're trying to do is you're trying to see areas that have a delay in contrast uptake, so delay in increased signal intensity, which again is going to correspond to a reduction in blood flow, because blood flow is going to, or the amount of gadolinium flowing into an area is directly related to the blood flow to that area during the first pass. And so here's an example of what the curves would look like if we were to actually go through, and I'm showing you two example areas here. One is in the anterior wall, and the other is in the infralateral wall. And then this is basically serial images that are taken over time as you do the rapid bolus of gadolinium contrast. And what you'll notice in the green area here is that fairly quickly you begin to see an increase in signal intensity. And if you actually plot that signal intensity curve, it looks like this. So there's initially no signal, and then all of a sudden you get a rapid upstroke, you achieve a peak, and then you get a decline in signal. Compare that green area there, the infralateral wall, to this area here in the anterior wall, where you can see if you measure the signal intensities, you can see there's a delay in the onset of the upslope, and there's also a delay in the peak. So again, you get the rise and then the gradual fall again. So this area here in red, corresponding to the anterior wall, would represent an area that has decreased blood supply compared to the infralateral wall during a hyperemic state. Now this is an animal study from almost 15 years ago, showing in fact that when you measure the signal intensity upslope and use that to derive what the blood flow is, and then you compare that between stress and rest, you can see that the blood flow ratio that you get between MRI assessment and between microsphere assessment is actually fairly tightly related. So there's a 1-to-1 relationship between the microsphere ratio of coronary flow reserve and what you measure on CMR based on signal intensity increases. And in fact, in this study, what they were able to demonstrate is that if you have a 70% stenosis, then you get a 50% reduction in the rate of coronary flow reserve, and that allows you to then be able to assess visually a signal intensity difference. So this was kind of one of the early studies showing that if you have a twofold difference, you're able to visualize this on unprocessed MR images. And then in this study, they also looked at what are the effects of when you go to higher and higher flow amounts. You'll notice that with MRI, there's a one-to-one relationship, whereas with most of the nuclear agents, whether it's SPECT or maybe SPECT or thallium SPECT, you actually see that there's a little bit of a plateau effect as you get to higher and higher flow rates. So whereas MRI gives you really a one-to-one relationship. So now let's talk about how we do this clinically. So move this out of the animal lab and let's move this into the clinical scanner. And so basically, again, two methodologies that you can use for vasodilatation. One is regadenoson, the other is adenosine. Now, is one preferred over the other? Yes, no? What's that?
What is used in our labs and what we use?
Yeah.
Yeah, we use regadenoson.
Okay. Why?
Selective cardiac.
It's better tolerated for side effects.
Okay. So side effect profile we think is better. Now let me ask you this: if you give adenosine, when do you typically see the side effects with adenosine?
Asthma.
What's that?
Asthma.
Okay, so patient, but I mean, during what time period do you typically see them? What's that? Do you begin to see symptoms immediately with adenosine? I guess maybe you guys haven't.
We don't ever get it.
You've never seen adenosine?
Yeah.
Okay.
Well,
So you don't have any experience with it. So,
Adenosine's more of an infusion, with the regadenoson is just a quick injection.
right. So regadenoson is a bolus, whereas adenosine is an infusion. So most adenosine protocols that are done for nuclear are 4 or 6 minute protocols, right? Typically, if you look at when most of the side effects occur, it's in the last couple minutes. So it's typically in minutes 4 to 6, right? Or minutes 3 to 6. With CMR, one of the unique things though is, so in nuclear, when do you actually inject the tracer? So if you're doing adenosine, and I guess maybe it's not fair because you guys don't have any experience with adenosine, but actually remember with nuclear what you have to do is you have to inject the tracer, you have to maintain hyperemia. So typically you inject the tracer halfway through your adenosine dosing, right? So if it's a 4 minute protocol, you inject it 2 minutes because you need to continue to maintain hyperemia for the tracer to fully deposit because you're going to image 20 minutes later. Whereas one of the advantages with MR is that you're actually imaging instantly, right? This is first pass imaging. So typically we'll begin the injection at 2 minutes after adenosine infusion, but then we stop imaging in about a minute, right? Because that's the duration of time that we require images during. So that by 3 minutes we turn it off. So from that standpoint, adenosine theoretically could actually be better tolerated in an MRI scanner because during the period of time when you begin to really have the symptoms, you've turned the infusion off. The one challenge though with adenosine in the MRI scanner is a practical issue, which is if I'm infusing adenosine through an IV line, well, remember how I do my first pass imaging is I'm giving a rapid bolus of gadolinium contrast. So I've got to have a separate line to do that because if I give a rapid bolus through the same line that the adenosine is going in, I'm basically giving a rapid bolus of adenosine. So you don't want to do that. So that's why in most MR labs they've switched to regadenoson, but it's not because of a tolerability issue. It's actually more because of patient comfort in the sense that you only need 1 IV as opposed to 2. Because with regadenoson, you just give 1 IV inject followed by saline, and then you do your perfusion imaging 30 seconds later. So now, and here's what the typical protocol would look like, which is you put the patient into the scanner, you acquire a set of cine images which allow you to look at wall motion, and ejection fraction and volumes. You then begin vasodilatation with your contrast injection. You do your stress perfusion imaging. You wait about 10 minutes or so to allow that first dose of contrast to dissipate. And then you go back and do a second round of rest perfusion imaging. So you now have stress and rest for comparison. And then we'll finish that off at the end with delayed enhancement MRI to look for myocardial scar, myocardial infarction. And so the total duration here is probably about an hour. So it's not 3 or 4 hours where you have to have the patient come back. You essentially can get all of this done in one shot. And then the typical contrast dosage that we use is about 0.15 millimolar per kilogram of gadolinium given over 2 doses, half during stress, half during rest. Okay, so the question then is, if we're doing multiple different data sets, so you have cine images, you have stress perfusion images, you have rest perfusion images, and you have delayed enhancement images, how do you then interpret all these different data sets? So we actually have an algorithm that we put together.
Just a question on that. Why would you do the rest? Why would you do the stress before the rest?
Okay, so that's a good question, and why don't you hold off on that, and I'll answer that for you in a second. Yeah. Okay, so in some ways it's similar to SPECT, but in a lot of ways it's different than SPECT when you do stress CMR. So one of the ways that you would say it's analogous in the sense that just like SPECT does, you want to look at all the data that you have. So in this case, you have 4 different pieces of data: stress, rest, delayed enhancement, as well as cine imaging. So the question then is, what's the algorithm that you utilize? What if there's a discordance between one and the other? So what I'm going to walk you through is this algorithm that we utilize. And so again, these are the 4 different sets of data sets. Cine images at rest, you have adenosine stress perfusion or regadenosine perfusion images. During stress, you have rest perfusion images, and then you have delayed enhancement images. And so this is the algorithm that's utilized. And again, this is the algorithm for identification of coronary disease. So for CAD detection, you actually start by looking at your delayed enhancement images first. And the idea is, if you have a patient who's presenting for evaluation of chest pain, if I see evidence of an infarct, then the guy's got to have coronary disease, right? Now, you could debate, well, is there obstructive coronary disease at this present time, but it's a CAD patient, essentially. And so that's why, and the other reason is because if you look at the image quality of the data, so your delayed enhancement, right, how long does it take to acquire that? How do we acquire those? Those are typically done as 1 breath held per image, right? So that's about 6 to 8 seconds to acquire 1 image. So you actually get a very high resolution. I go back, and you can see, if you look at the image quality of your delayed enhancement images, it's much better than the image quality of your perfusion images, right? And the reason is these perfusion images, I have to actually get 3 or 4 images per heartbeat, right? Because I want to get full coverage of the heart, and I want to keep doing this repeatedly as I'm giving gadolinium bolus. So we're imaging every single heartbeat, and I have to get 4 images within 1 heartbeat, whereas the delayed enhancement images, I get 1 image over 6 heartbeats. Right? So the image quality for your delayed enhancement is much better. So it's less prone to artifacts, it's much higher signal to noise, and also it's a much better T1 weighted technique, but it takes more time to do. And so that's why you always want to, so we would place the greatest emphasis on that. So you start out by looking at your delayed enhancement images first. And so here's an example of a patient who, and most of these are actually from a study that we did. This is when I was a fellow myself. One of the studies that we did, where we said, okay, let's look at a series of 100 patients going to the cath lab and say, let's use this kind of systematic algorithm and see how well it performs. And so this is a person who has an area of hyperenhancement in the infralateral wall, right, in the lateral wall. So this person, despite the fact that my stress perfusion and rest perfusion images don't really show me an abnormality, I would say this person has coronary disease. Again, just simply based on the fact, if I start with my delayed enhancement and that's positive, then you've made the diagnosis of CAD. Now again, this is the algorithm that's used for CAD detection. It's different than if you're doing it in patients with known CAD and you're trying to find ischemic burden. The way you would approach it is a little bit different. But for patients presenting for CAD assessment, you would say this is a positive study. And in fact, this person, when they went to the cath lab, they had a lesion here in the obtuse marginal, which corresponds to that lateral wall infarction. Now, what happens if your delayed enhancement is negative? Then the next step then is you go and you look at your stress perfusion data set. And so I'm showing you now, so this patient, the delayed enhancement was normal. So we're looking now at the stress perfusion. And the left-hand side is stress. The right-hand side here is rest perfusion. When I look at my stress perfusion, what does it look like? And what you're trying to see is, does all areas of your myocardium fill in with contrast at the same rate, or is there any areas that are delayed? So this is just, again, a visual assessment methodology here. And what do you think?
Anterior is delayed.
Right, so you've got this area here, which is the anterior wall and the anterior septum, right? That has a delayed contrast uptake compared to the inferior lateral walls, right? So based on our algorithm, we say here the stress perfusion is abnormal, positive. If the stress perfusion was normal, you would say you're done, no CAD, that's the end of the test. If it's positive, then you go on to look at rest perfusion, and then how does my rest perfusion look? Right? What you want to look for is there a match defect or is there a mismatch? So is the defect that I see here on stress the same as what I see on rest, or is there a mismatch? There's a mismatch, right? Because the rest perfusion, it's not really that impressive for showing a perfusion defect, whereas the stress perfusion is markedly abnormal. So if I have a mismatch or reversible defect, that indicates coronary disease. And so in this person, when they went on to the cath lab, and again you can see delayed enhancement was normal. I'm just showing you a still image here that the stress perfusion shows an abnormality. Rest perfusion does not, so you have a mismatch defect or reversible defect. And in fact, there is a lesion here in the proximal LAD in this patient. Yep.
So what would cause a matched defect in the stress and rest?
Okay, so that's a good question. So one thing is, based on our algorithm, we would say a matched defect means no coronary disease, right? So and I'll show you. Right. So let me. So again, the reason. Remember, it's a little bit different than nuclear because we already know if there's an infarct, right? So I know if there's an infarct based on my delayed enhancement. And if I'm looking for infarct, the delayed enhancement is the thing I'm going to look at to find infarct. Okay. So there's actually a fundamental reason why if you have a fixed defect, it's not indicative of an infarction, in fact. An infarct will not give you a fixed defect. And why is that? That's because if I do my stress images, I've given a dose of contrast, right? Now, what does an infarct do with contrast? It hangs on to it in the delayed phase, right? Remember, it's delayed enhancement. So in the early phase, an infarct will not show enhancement because there's reduced perfusion. Because in the very first pass, it's based on blood flow. In the delayed phase, on the other hand, the infarct actually holds on to gadolinium. So in the delayed phase, you actually would have contrast uptake. So as a result, your rest perfusion images, if you had an infarct, would never show a defect. Because they actually would, in fact, if you look at the rest perfusion images, even before you give the second dose of contrast, there's actually a little bit of enhancement there. All right. So as a result, an infarct does not give you a fixed defect. An infarct actually gives you a mismatch defect, but you'll know that is a mismatch due to infarct because again you'll know what the infarct is on delayed enhancement, and that's how you modify this algorithm in a patient who has known coronary disease, where somebody who has known infarction and you're really looking for ischemia. What you would do is compare the stress perfusion to your delayed enhancement, not compare the stress to your rest, but rather compare the stress perfusion to your delayed enhancement. Now that gets to the question of why would you do stress perfusion before rest perfusion, right? And that was your question, Rob? And the reason for that is if you think about it, if I do my rest perfusion first, right, then if I have any areas of infarction, when I go to do my stress perfusion, those areas of the infarction wouldn't show a defect, right, because they've already got contrast, right? So all of a sudden now you get this bizarre perfusion. So if you have a perfusion defect during stress that's larger than the infarct, the defect would look very unusual. It wouldn't look like a normal perfusion defect that you would see. It wouldn't match a coronary territory. So it gets very confusing then to discriminate that from artifact, because the reality is that the perfusion images do suffer from artifacts. I mean, that's, because these are images you're trying to get 4 images per heartbeat as opposed to 1 image per 6 or 8 heartbeats. Does that make sense? I want to make sure.
Yeah, I guess the question is, so in the reason the nuclear, right? So the regadenoson molecule in theory has a longer half-life, right? I mean that's why I presume, is that correct or no?
Regadenoson, yes. Regadenoson hyperemic effects last for about 10 minutes.
Okay. So I mean the concern would be that you still have regadenoson when you
do your rest perfusion.
When you do your rest perfusion.
Right. So that's why for CMR what we do is we always reverse patients before we do rest perfusion.
Oh, how do you reverse a patient?
So aminophylline.
Really?
You just give them aminophylline, yeah. Well, that's what you would do. The same thing you would do in the nuclear lab if a patient's having side effects from regadenoson.
And that'll fix this problem.
Which problem?
The problem of potentially having a match defect.
No. That's a fundamental issue. Okay, so let's go back.
No, so I guess my concern is if they were still hyperemic when you acquired your second set of images.
Right.
Aminophylline will.
Yes. So aminophylline reverses the hyperemia. So one is if you wait 10 minutes, most of the hyperemic effects go away, although not completely. The other thing is you give aminophylline as well to really try to get the hyperemic effects to go away, so that when you're doing your stress images, you're in hyperemia. When you're doing your rest images, you're in a resting state.
And would you
Okay.
also do that if you use traditional adenosine? Or
No. So with regular adenosine, once you turn it off, the effects are gone within a couple of minutes. So when we used to use adenosine, you do the adenosine imaging, you turn it off, and then by 10 minutes later, when you do your rest imaging, the hyperemic effects are gone. So you don't need to reverse. So in the adenosine days, the only time you reverse is if somebody had a very bad symptomatic reaction to adenosine. That would be the only time you would reverse them. Okay? So, but again, I want to make sure we don't mix two different things, right? So the reason for the fixed defect has nothing to do with regadenosin or adenosine, right? The idea of a fixed defect being from artifact, and I'll show you, has to do with the fact that an infarct would not give you a fixed defect. So if you see a fixed defect, you know it cannot be from an infarct, right? So basically, if you have ischemia, if you just have a reversible defect, if you just have coronary disease with no infarction, you have ischemia, you'll get a reversible defect. If you have an infarct, you would also get a reversible defect. And the reason for that is, remember, when you do your rest images after your stress images, those rest images, when you do the rest images, you've already given a dose of contrast beforehand, right? So wherever there's infarct, that infarct will take up contrast. Does that make sense? Right, so I'm not sure.
No, I guess I'm not sure I buy it, but it's possible.
Okay, yeah.
Because, like, what if we just had ischemia? So let's say we had the concept of ischemia. Let's say we had a symptomatic lesion, right, that was greater than 70%, but was not causing tissue damage.
Right, then you would see a reversible defect.
Your delayed enhancement would be
But your
negative.
delayed enhancement
So your delayed enhancement would be
Stress
negative.
would be positive, and your rest would be negative.
Ischemia, infarction, stress, rest look the same. But
So
where you
this has
differentiate
to do with the
delayed
kinetics of gadolinium, right? The kinetics of gadolinium are such that during first pass, it's based on blood flow alone. In the delayed phase, after 5 or 10 minutes of the contrast injection, infarct actually takes up contrast, right? Infarct holds on to contrast. So what happens is, during first pass, both an infarct would show a perfusion defect, just like ischemia would. The problem is that on 5 or 10 minutes later, that infarct holds on to contrast. So you can't have a perfusion defect when you do a second perfusion run, because that infarct is holding on to contrast that you gave before, right? Now that principle wouldn't be there if I did the rest perfusion first, right? But the problem is you have to do one after the other, and what you don't want to do is corrupt your stress images, and that's why you do the stress images first. And then, all right, let's go. So yeah, just a couple other things, differences between the CMR and between nuclear-based techniques. Obviously, if you look at spatial resolution, the CMR images, the spatial resolution is about 3 by 3 millimeters with an 8 millimeter thick slice, whereas with SPECT, it's about a 10 by 10 by 10. The other difference is that with stress, or with SPECT, you're essentially taking images throughout the entire cardiac cycle, so you don't have gating per se, right? When you do the gated SPECT, that's not actually to look at perfusion. They're using that just for the wall motion part. So the SPECT images are primarily taken without gating, whereas here we have to actually acquire the images over a very short duration, typically about 150 milliseconds, right? Because you want to get about 3 to 4 images per heartbeat, so you get at least 3 to 4 slices through the left ventricle. And then the other principle, I think, difference is that with nuclear-based techniques, they require an intact cell membrane in addition to perfusion, whereas with CMR-based techniques, it's really just a function of whatever the flow is to that area. You don't need to have intact cell membranes. Okay, so the question is, what's the value in the rest images? It's actually to look for artifacts. So if you look here, stress images here, what do you guys think on the left-hand side? There's an area here in the infraseptum, right? And if you look at the rest images, what do you think? Looks like there's a defect that's there as well, right? And that's an artifact. And so one of the things we know is that there's certain classic areas, just like in nuclear, there's certain areas where you get artifacts. So one of the areas you oftentimes will get it is in this infraseptal area. And again, you'll see this isolated to 1 or 2 slices. It doesn't match a coronary perfusion territory. The other artifact you can sometimes get is this thing called a dark rim artifact, where you get just 1 pixel all the way around that looks like it's abnormal. And again, there's kind of technical reasons for that. But so, as with any technique, you need to recognize what the artifacts are and be able to know how to read around those artifacts. And in this person, the delayed enhancement was normal, fixed perfusion defect, normal coronary artery disease, or no coronary artery disease. So now the question, somebody may say is, okay, so if I say that a fixed defect automatically implies it's an artifact, what if I have severe resting ischemia, right? Then I could actually have a fixed defect, right? You could have truly fixed perfusion abnormality. So the question is, does this approach have a problem if you have somebody who has significant resting ischemia? And the answer to that, actually, I would tell you is that if you have significant resting ischemia, so you have a perfusion defect both at stress and rest, that's not an artifact. That's actually due to real reduced blood supply alone. You would expect to see wall motion abnormality, right? So that's where the cine images come into play, not only to get an assessment of EF, but if I see an area. So the way I kind of practically approach this is we start out by looking at delayed enhancement. If it's positive, diagnosis of CAD is made. If it's negative, then you look at the stress perfusion images, and if those are negative, then that's it. You're done. No CAD. If the stress perfusion images, on the other hand, are positive, then I look at the rest perfusion images. If there's a reversible defect, you say, yes, this is indicative of coronary disease. On the flip side, if there's a matched defect, so I see a defect present at stress and rest, the one caveat to this is I'll look at my my cine images, and if I see a wall motion abnormality that fits exactly in that same distribution, then that would raise a concern that could there be significant resting ischemia. Obviously, it's a rare condition, but that's one possibility. So that's one modification to this algorithm right here. Is before you say it's artifact and it's no CAD, you want to make sure you look at the cine images at that location. Okay, so and then this is just data from a couple of different studies that I'm going to show you quickly. And let me just kind of, in the interest of time, skip through this and go through a meta-analysis which was published a couple years ago, which looked at really numerous studies with vasodilator stress CMR perfusion imaging, looking at a pool sensitivity of about 89% and a pool specificity of about 80%. So you can see these studies go back, almost the last 10 or 15 years. So there's a wealth of data that's come out. Now there's obviously continued improvements to the techniques, just like they are with all modalities. And then lastly, in addition to diagnostic accuracy, there's also data showing prognostic value. And this is prognostic value with dobutamine, stress CMR, again looking at heart events as well as the incidence of late revascularization in people with no inducible ischemia versus those patients who had evidence of inducible ischemia on a dobutamine CMR. And then this is just a composite table of several different studies looking at the predictive value of dobutamine CMR. And then this now is looking at vasodilator CMR. And again, you have similar findings, which is that if you have evidence of perfusion abnormalities, that is associated with a worse outcome, whether it be heart events such as death and MI or MACE events. Patients with evidence of perfusion abnormalities have a worse outcome than patients without. Let me skip past this in the interest of time, and let's just go through some example cases. So here's one. This is a 54-year-old gentleman who has about a 6-month history of exertional dyspnea, has no classic anginal symptoms. He initially got a plain old treadmill stress test, which only went about 3 minutes and was terminated due to dyspnea. So this guy, he's about 5'5" and he's about 250 pounds. And so the question is he just deconditioned, and that's why he's only going 3 minutes? There were no EKG changes per se on the treadmill. So he was actually referred for a stress CMR. And let me show you this stress CMR. And I wonder if maybe we can adjust the brightness a little bit here on the big screen. Okay. Make the brightness a little bit brighter. Just a little bit, because it's not too bad actually. Oops, a little brighter. Yeah, that's good. That's good right there. Okay, so let's start out. And again, you'll notice all the different sets of images. You have cine images, stress perfusion, rest perfusion, and then below that, your delayed enhancement images. So let's start out. And again, so if we approach this by the algorithm that we talked about, I would start out by looking at delayed enhancement images first. And what do you see? And again, you guys are all familiar with delayed enhancement, what you're looking for, right? Basically areas of increased signal, hyper enhancement, okay? And remember, this is done 5 to 10 minutes after administration of gadolinium contrast, and each of these images is taken with one breath hold, so it's about 6 to 8 heartbeats required. What do you guys think? So you basically have a short axis view that goes from the base all the way down to the apex, and then we have the standard long axis views.
Like in the mid interlateral.
Looks okay.
On which slice?
So the fourth one. That's the
1, 2, 3, 4 slice.
top, like
This
up.
one?
The top part of it.
No, yeah.
This one right here, the top part of it?
Yeah.
Anterior
That'd be-
wall?
yeah.
You wonder if there's something there? Okay. Okay. What do you guys think? How many say yes? There's an infarct. One. Jeff, you brought
I'm
it
not
up.
100% convinced on it yet.
Okay, questionable. All right, who says no? Everybody else says no. Okay, all right. So so the majority's rule says no delay enhancement. So now our algorithm, we look at our stress images, okay? And let me see if I can click on these so you can see them one by one. Okay, so here's your stress images. And again, you're looking for any areas that have delayed contrast uptake or wash-in. Anything here?
Inferior septal.
Okay, so you wonder about the infraseptal. Okay, so let's go. And obviously what you want to see is you want to see, you don't want to just see it in isolation. Let's look at serial slices, and we want to make sure that things match a coronary perfusion territory. So here,
Still the same.
what do you think?
There's something coming up in
Okay, so here you think there's a perfusion defect from here,
Yeah, no, septum.
inferior, septum, and how about the anterior wall?
Also anterior.
Well, like compare the septum to the lateral wall. Much. Lateral wall so
Yeah,
the septum.
Okay. So we'd say the inferior wall, the septum, maybe the anterior wall, but the lateral wall looks like it's the one that fills in the best, we think? Okay. And then, let's go to the next one. How about this one? And again, I mean, this projector is not the best, but what do you guys think?
It's not fitting at all. Except for.
What's that?
It's not fitting at all now.
Okay,
And then
so
inferior-
you're seeing consistency, right?
Yeah.
You're seeing, and what territories are we talking about here? Or territory?
Probably LED.
Right, LED.
LED, then, yeah, right.
Right.
Yeah, LED and right, correct? Because the anterior interseptum and then going down to the inferior wall at the base. And then here's our apical slice here. And again, you can see the lateral wall fills in, but you got really an area from almost 1 o'clock to about 5 o'clock, right?
Yeah.
Okay. So make note of that defect that you saw. Now what we're going to do, based on our algorithm, the next step will be to compare that to our rest images, right? And see if this defect is matched. Okay, so here's our rest images now. Okay. So, and then what we'll do in the lab typically is we'll pull them up side by side, because I have dual screen monitors. So you can actually just compare side by side and say, okay, is it matched or mismatched? What do you think here?
Still looks okay, I think. So no matched defect.
Right, so it's a mismatch, right? Reversible
Mismatch,
defect,
yeah.
reversible defect, okay. Here you go, and then here. Okay, so we'd say reversible defect. Okay, so our algorithm then basically is positive on stress for perfusion defect. That's not present on rest, therefore indicative of coronary disease. And you would say indicative of coronary disease in one vessel? Okay, 2 vessel territory at least, right? Okay. Anybody disagree with that? Now, one thing I will point out to you, and somebody I think picked up on this, but weren't confident in it.
Yeah.
That little area right there, right?
Mm-hmm.
Okay. And it was actually the slice, you were pointing to this slice right here. Oh, sorry. Okay, you were pointing to this slice right here, but the one before it actually, I think, showed it better, right? And remember, when you're trying to look for a small subendocardial infarct, because one of the challenges can be trying to find an area that's bright next to a cavity that's bright, right? So what are the things that you can do is, one is if we've done imaging a little bit later on, right? Because what happens is the contrast in the cavity gradually keeps getting less and less and less. And that's why this image actually is a little bit better, because you can look at it. This is series number 65, right? Whereas the previous one was series number 48. So you know that the first one was taken a little bit later, right? What happened is they went back and redid it. So they went through and kind of did our full stack of delayed enhancement, and then something looked funny, so we went back and said, let's do it again now that the contrast has faded away a little bit. So one thing is always look if there's later images. The other thing to do, though, is compare if you're trying to look for a subendocardial infarct, okay, what is the amount of black viable myocardium, right? Make note of how much there is in the septum, inferior wall, lateral wall, and the anterior wall, right? Compare that to your cine, right? And obviously you want to pause the cine diastole. And remember, in the anterior wall, it looked like there's very little black viable myocardium. Well, you know, yes, there's less viable myocardium in the anterior wall than there is in the septum or inferior wall, right? But it wasn't as little as what you saw. So that's another clue that there's actually a subendocardial infarct that's present there. And then the third thing to do always is look at orthogonal views. So if you see something that looks funny, and that's why I didn't prompt you there, but look at an orthogonal view through that, which is going to be your two-chamber view. And one of the things we always try to do, if we see anything at all on the short axis that looks funny, I always tell the text to go back and do that specific location. So even if it's an off-axis 2 or 4 or whatever, try to make sure you get a view that goes through that. In this case, I think you can appreciate this a little bit better, right? That there in fact is a little hyper-enhancement here. So there actually is a small little subendocardial infarct here in the anterior wall as well. And this person went on to get cath, and he had, in fact, disease, high-grade lesions in his, so we said there's, in his LAD and his right coronary, and he also had kind of the 70% lesion in the OM. All right, and this guy then went on to get CABG and was doing well. So I'll show you another case. This is a 56-year-old woman who presents to you with angina. All right, now her story is about a month ago she came to the hospital, was having anginal symptoms, had a cath, had a 99% osteo-LAD and a 60% mid-LAD. You know, at that time, and again, this is a case from probably 10 years ago. You know, the interventionist was concerned about the osteo-LAD location, so he sent her on for a limit LAD graft. All right. So she comes back now a month later, and she's still having chest pain. The question is, was her chest pain really, ischemic chest pain, or was it something else that she continues to have, or did her grafts go down, or something else? All right. So now let me show you her stress. And so again, what we want to do, remember the algorithm we want to do is start with our delayed enhancement images first. And what do you think on these delayed? Let me see if I can magnify this one notch. Okay. So if you look at our delayed enhancement images, what do you think? So basal, mid, apical, and then you've got your 2-chamber and your 3-chamber views.
Looks okay.
Yeah, looks okay, right? So no evidence of infarct. So we say no delayed enhancement. Now, remember the modification to the algorithm. This is a patient with known CAD, right? So what we're looking at here is what we would do. We know this person's got CAD, so even if she had delayed enhancement, that wouldn't, be a positive test in the sense that what we're trying to look for is ischemia. So we would compare our stress to our delayed enhancement. In this case, the delayed enhancement is fine. Now let's look at our stress perfusion. And what do you think?
So the anterior septum.
Okay, so you've got an area in the anterior septum, right? Okay. And so again, let's take a look at the next slice. take a look at that. And then one more. What do you guys think? And then the very apical stress whoops. Okay, and then the rest perfusion. So do you see a defect here? So you see a reversible defect, right? So the question is Lima graft?
Patent.
It's patent. And what's going on?
Mid-LED stenosis.
Right, so the clue here I think was, if you look at the basal slices, you see definitely a pretty dense perfusion defect, right? But what about when you go down to the apical slices? Especially this very last apical slice. You don't see a perfusion defect here, right? So the problem in this patient's case was the Lima graft was patent. The problem was that proximal LED, that was 99%, and the Lima graft was going in distal to that second lesion, and there just was not adequate backfilling, right? And that's the problem. So again, make sure you look at all of the images. Don't get trapped by saying, okay, I looked at a couple images, it looks abnormal, therefore I think there's an abnormality. You want to really try to localize where the abnormality is. Okay, so I think we're over time, so thank you all for your attention.